but we'll put that in the chat as well. Um, so I think why don't we go ahead and get started because we have we could have a lot of content here to cover if we want to. We have more than what we can get into in an hour. I can tell you that much. And so I sent an email out to everybody this morning on this, but this is kind of a planned kind of third third in this series, so to speak. It is kind of a way to stagger our learning and kind of get some of that layered learning. And so if you remember, um, excuse me, last summer, I think it was in June or so, Dr. Townley came and we talked a lot about some of the workup, and I think we went into detail on the different screenings and the STMS and touched on that blood test, which at that time was really new and we hadn't really had a lot of experience with. And then we had another session, I think it was in August, and we really hit on the new anti-amyloid, these IV kind of therapy treatments and did that. And so, at this stage, we've got about a year more of experience of this workup that we've been doing in our primary care clinics in terms of in the neurocog assessments, but also utilizing these new serum blood tests and that sort of thing. And so I'm sure many of you are like myself that now you have a little bit more nuanced questions on this. And so hopefully we can kind of dive into that a little bit today. We have a representative case that I just literally pulled off the shelf on Tuesday. I think we're seeing tons of dementia syndromes in our clinics now, and as we've gotten better at screening them and detecting them and things like that. So this is certainly top of mind for many of our practices here. So we'll do very brief introductions because I think we all know, our presenters today. So Dr. Townley, I think we all know he's done several of our primary care grand rounds here. One of our cognitive neurologists certainly does a lot of research in this area, but he's also been kind of at the forefront on some of the operations and really the coordination of care between primary care and our brain health clinic. We have Jeff Burns, who's very well known for his work in this space as well. Been a great partner for primary care as well. And so some of the work that they're doing really is transforming the way we approach Alzheimer's and other dementias, really nationally and internationally. And so fortunate to have you guys here at KU and in Kansas City. I don't know if you have others that are going to be kind of jumping in on the conversation that we need to make sure and introduce, or I don't want to leave anybody out.
I don't
Well,
think Lindsay's attending, is she?
I don't see her, but we do
Lindsay,
have
yeah.
Dr. Byer here,
Yeah.
who is a family medicine trained geriatrician who joined our memory clinic to focus on memory
Okay.
just a month ago or so. And so, Dr.
Hi,
Byer,
nice to meet you.
Oh, Dr. Byer, welcome. That's awesome.
and
So,
then just to Dr. Townley is the medical director of the memory clinic. So all the change, he's been driving all these changes and restructurings and over, I don't know how long you've been doing this, Ryan. How long you,
This is
at least
about 4 years in
4 years.
now. Yeah.
But yeah, so
yeah, doing a great job. So, I think the goals of the day, we're gonna review some of those topics, around the basics on the clinical care, the workup, and maybe some into the treatments and stuff. But I'm hoping that we can really talk a lot about, how the brain health clinic has developed and evolved over time. These kind of pathways that you all have developed and how we could best utilize those. And then if we have some time, personally, I'm going to be really interested to hear about some of your work even beyond KU and out in across the state of Kansas and things like that. And so, with that, I think we'll start with our representative case here, and then we'll kind of dive in from there. As always, please jump in with questions, comments, in the chat or raise your hand. We want this to be interactive and useful in the discussion with everybody here. Okay, so earlier this week I saw Mrs. S for follow-up. This is really a follow-up visit, but I had seen her previously for her Medicare wellness visit. At that time, she was accompanied by her husband. She does have a past history of myasthenia gravis, coronary disease, hypertension, hyperlipidemia, hypothyroidism. And both of them, and really her husband was telling me most of this, but they've noticed worsening memory troubles over the past couple of years. The area that they brought up that they noticed the most was with cooking. So she was kind of cooking was one of her passions, and she was kind of forgetting different ingredients and having more trouble kind of following recipes and things of that nature. And I don't really remember why we had done this, but in 2019 we had done an MMSE on her, so we did have that kind of baseline objective scoring. And at that time, she had scored 29 out of 30. But when we put her through neurocognitive testing with Mary Kaiser, one of our nurse practitioners, one who did that for us within our clinic, she scored 17 out of 38 on her STMS. And so certainly some objective evidence of cognitive impairment. She had a normal TSH, B12 limit. We were within normal limits. And so before we kind of start talking about some of the workup and lab findings and that sort of stuff, I was wondering if you could, Ryan, if you could just kind of give us a little bit of refresh on the trends in Alzheimer's disease, in particular, epidemiologic trends, what you're seeing here in our local community, and just kind of give us a little bit of kind of bigger picture background and kind of frame this case. Oh, you're on mute, Ryan.
Yeah, unmute. Yeah, it's a great segue. The part of this is too, we've kind of changed how we're detecting Alzheimer's disease, how we can detect it earlier. I think in the past it just was always synonymous with dementia, right? There's kind of only these interchangeable terms of dementia and Alzheimer's, but we've learned a lot more than that, and that it's really a 30-year disease that happens in the brain. It's not something that happens, once someone stops cooking. So it's how can we detect it earlier? How can we, you hit the nail on the head with, like, there must have been something back in 2019 going on to make you guys do an MSE. But what we're learning now, because we were doing MSE here in the memory clinic even up until a couple of years ago, it's just not a great screening tool. It's not a good tool for detecting early changes. It's about 18% successful in doing that. So it could have been that if we did an STMS or something like neuropsych testing back then, we might have detected that very subtle, mild cognitive impairment change back then. But what we're seeing in the numbers, so it's as you kind of incorporate that mild cognitive impairment into the definition, 11% or basically 1 in 9 individuals over age 65 have Alzheimer's disease. So think of your average 65-year-old in your clinic, 1 in 9 of them has Alzheimer's disease going on. And then if you go out to 85, then we're talking 1 in 3. So you're each 5 years we're seeing an uptick in that percentage, right? So it's a disease of aging. We got many more patients that are living to be 75, 80, 85, and so the prevalence is just exploding, which we see in our referral numbers too. So yeah, we've seen, so like when I started at KU back in 2019, we would get about 1,400 referrals a year for the year for new patients. And I just looked at the numbers today for the last 2.5 months, so April to now, we're at 1,100 referrals for 2.5 months, and we're going to exceed 3,500 referrals. So it's ballooned.
Yeah, likely to keep going up, I'm sure, right? So, so one of the things, we're in our Medicare wellness visits now, we're screening everybody with a mini cog, So they do the clock draw, they do the 3-item recall. If that's good, I think most of us are just kind of moving on. But is there, thinking about these, 1 in 9 over 65, and then that guy going up and up as they age, is there anything that we should be maybe asking about history, or is there any kind of things that you kind of your go-tos when you're trying to kind of question a patient or something like that, is to help us maybe detect a few more of these things earlier?
I think, so the mini cog is pretty good about dementia detection, right? So when it's abnormal, it can be quite helpful. It's still it's actually surprisingly a little bit better than MSE for even early changes. But its detection for MCI is still a little bit weak, especially if you're using 3 as your cutoff. Uh, I think honestly, like a simple thing, we really like this 88 tool. So you guys are using that now in your cognitive assessment workflow. That's something that could probably be the only difficulty about it is when you're seeing your usual Medicare wellness patient back, right? They don't necessarily always have someone that can answer that. It would be a self uh, questionnaire in a lot of cases, but that could be something even a nurse could follow up on. Hey, can we just reach out to your your daughter or your spouse and run these 8 questions by them? And if that's, getting flagged, then that's where you'd maybe want to help set up a cognitive assessment visit at that point.
It's interesting you mentioned that if you're using 3 as your cutoff, like all of us use 3 as the cutoff because that's what the Medicare wellness visit tells
Yep.
us we should use as the cutoff. So is there a
Yeah.
do this? I mean, is it better?
Yeah.
I've always thought it was weird if they get the clock right, but they only get 1 out of 3 words. I'm like, that's really weird. You're 67, you're getting 1 out of 3 words. It's always seemed weird to be like, that's normal. You're fine.
Yeah.
Yeah.
Yeah, no, I think that's where like even if you're seeing just a subtle change, that's probably where you'd want to do an 88, right? And just see, are we missing something? Because those earliest changes are not always going to be noticed by the patient. So you asked the right question, Brandon, but it's like you could ask the patient any question you wanted, but if they aren't aware of the changes, then it's not going to be helpful, right?
Oh, there we
So
go.
it's almost, do we need to loop someone else in at that point is the major decision there.
Yeah, like collateral information, what you're looking for, right? Okay. All right, very good. So yeah, obviously epidemiology, we're seeing higher trends. We're getting better at detecting this, although there's lots of room for improvement there. And then that's translating into lots of need for your all services. And so we'll get into that here as we go forward on this. So just to kind of keep this one moving forward, let me pull up the chat there just to make sure we're not missing anything on that. We get a brain MRI. So, I followed, Ryan's advice on this, that he's talked to us about in the past. So I got an MRI that showed, and I feel like every MRI I get has the exact same read. And the read was a mild generalized cerebral volume loss without clear pattern of atrophy. And then there was some mild non-specific cerebral white matter hyperintensities. I think I feel like every time I get it, that's the read I get. Even though that we're kind of specifying, I think what we're looking for in the primary care world is like, we're not neuroradiologists, nor are we cognitive neurologists. We're kind of looking for a little bit of help in this area. But is there anything that maybe any advice you would have on us, or anything that maybe even we could be looking for specifically on these MRI scans if we're pulling up the images ourselves?
Yeah, I think it's gonna be pretty hard for you guys to detect subtle changes. I mean, certainly for the folks that do this regularly, like our nurse practitioners, Dr. Byers, learning very quickly, anyone that once you start to look at hundreds of them, you start to notice these patterns, but it's mostly looking at atrophy of specifically the hippocampus structures. And you're exactly right. Even the neuroradiologists aren't exactly trained to do that. So you're not going to see them quantify a temporal atrophy score on there. We've tried multiple times to try to introduce something like a neuro quantification software, something that would at least call out what is this person's atrophy based on their percentile age. It's an expensive program. Nobody's like run with it with radiology. So we're kind of still stuck in the past of is there a tumor, stroke, or something big? That's what they're really looking at. They're not trained necessarily to look at subtle detection of parietal atrophy, and that's more of what we do. So that would be one of those scenarios that like we have to have that variable, right? We have to have that MRI available to review. That's a potential really good reason to do an e-consult because we can quickly look at an image and let you know if there's something concerning or not.
Yeah, that's kind of what we did on this one, right? And so I'm sure, I don't know, ever thrown one of these images and open evidence or something.
Oh,
That's it. So I'm sure it can quantify it for us.
Yes.
We'll use AI to our advantage. All right, so we get the MRI like we usually do. And that kind of a vague reading on that, and then I order the p-tau amyloid test. So obviously, I think a year ago we'd never even heard of this test, and we've started ordering more and more of these, and we got a result of 0.03056. The upper limit of normal is 0.0092. So this is a ratio. So I think really the crux of this, and there's like kind of negative, there's intermediate, and then there's positive, and the positive is greater than or equal to 0.01. They're kind of small numbers, right? So I think as I'm getting more of these, I've noticed that there's a fairly wide variability in the magnitude of that ratio. Which I guess my primary question is does that mean anything? Is this like a positive or not? Or is it like, if it's like really high, boy, this is really a slam dunk for Alzheimer's? I guess I'm really,
Yeah.
the crux is like, how can I misinterpret this? I guess I want to make sure I avoid that.
Good. It's a good question. I mean, there's still stuff we need to learn about it. I mean, we treat it as binary right now, with obviously that gray zone intermediate range that might require further like amyloid PET type of thing. But everything that I'm seeing, and I'll certainly let Jeff weigh in too, but it probably is quantifying the amount of pathology going on. The majority of what we're measuring here is amyloid plaques, like the load in the brain. But as you get more amyloid plaques, you get more irritation of the phosphorylated tau, and you get more release of the p-tau 217, which is one of the components we're measuring. And there's a certain amount of this value, especially when it's super high, that's probably measuring actual tau in the brain. And those patients are just more likely to be further along in their biologic disease process. But it's not a 1-to-1 ratio either. So it's, we have some people that come back with very high levels that are still very mild changes. That gets a lot more complicated when you think about things like cognitive reserve. They're able to deal. It's probably they still have the same underlying more pathology, but they're compensating for it pretty well. But yeah, I think you can just be more confident in your, in calling it Alzheimer's when it's clearly positive, right? I think that's the main takeaway. And when it's more subtle, when it's like right at the border, that's where we need to make sure there's not things like kidney disease, because you asked another question of like, what else could elevate this thing, right? And well, if we're like right at the border and they've got, an EGFR of 50, or even lower than that, then that's where we need to be thinking maybe this could be kidney disease driving this little false elevation.
Yeah, that's good. A lot of our patients do have CKD, right? So, Jeff, you have something.
I'm just gonna say that's right on. The further from the cut point, the more likely it's elevated amyloid in the brain. So that's a test that reflects amyloid in the brain. So yeah, the further from that cut point, the more likely. And at some point, it becomes sort of slam dunk. But what's really hard, because it's 0.00, and these are numbers, they're hard numbers to interpret. It's hard to know when it's far from the cut point. So, and we don't have great ways of showing you that. But yeah, but the further away, the burden does matter. I mean, the higher the test, the more, that there's amyloid, and the more amyloid is likely present. So I'm basically restating what Dr. Townley just laid out, but yeah, fully agree.
We talked about you were saying if something's in an intermediate range. I thought last time we were talking about how we would retest it and then kind of go from there in like 6 months or something like that. But you kind of mentioned maybe going for a amyloid PET in that situation. So I just wanted to kind of tease that out too.
Yeah, I think it's that becomes a little bit more practitioner dependent. So like for us in the Alzheimer's clinic and the memory clinic, we're gonna go to get some specialized testing because something's going on, to make it into our clinic. For if it's kind of subtle changes, and there's certainly some uncertainty even about what level of concern we have. I think a repeating test is totally reasonable too.
Is there anything else that can cause this to be elevated besides kidney disease? I guess kidney disease.
Yeah.
Is there anything else? And I guess I bring this up. I was just kind of pulling this up. Obviously, I'm not going to share this. It's got the chart pulled up. But yeah, I had a patient who's had progressive Parkinson's recently, but then like some kind of more subtle changes, and it's kind of scored poorly. So anyway, I ordered that, and it was 0.01. And so now it seems like two things going on, right?
Yep.
Is that I
You're
just
spot
wanna-
on. So
Causes
you,
I need to be aware of.
you've probably detected co-pathology. Yeah.
Yeah.
So the other thing that you do need to know, at least that could falsely elevate it, and maybe falsely is the wrong word, but like a major damage to the brain, stroke, TBI, especially in the acute setting, could spike up the p-tau level. So so like if they've had a very recent TBI or stroke within the last, couple weeks, then you wouldn't want to rely on that test in that scenario. But yeah, so Parkinson's disease in and of itself should not cause an elevation of this. It's pretty specific to Alzheimer's disease, outside of the kidney, and maybe it's helpful just to explain. So the reason why kidney's elevated, it's just because it's not getting cleared. So it's just building up in the blood more, so it's falsely elevated in that sense, right? And the reason it's elevated in stroke is because there's brain damage and there's release of this tau protein out into the system. So that can help people remember it. But yeah, if you've got a patient that has very clear vascular disease in the brain, it's chronic, it's not an acute stroke situation, but they have an elevated p-tau, like they probably have co-pathology of vascular and Alzheimer's, right? You got a very clear Parkinson's patient, they got some memory changes going on too, and you get an elevated p-tau, then you've probably detected they've got Alzheimer's, and that those two can run together very often. So in an autopsy related studies like Lewy body proteins, which is what are in Parkinson's patients, and Alzheimer's proteins can run together anywhere from 20 to 40% of the time, depending on the study you look at. So,
Yeah. Okay. Yeah, this is helpful. Any other questions on the p-tau amyloid testing before we move on from the crowd?
can I share while somebody thinks of questions? I'll just share. Jeff shared this with me. This what we've seen in the ordering, because you guys are in here. So this is like the number of p-tau tests since we released them in April of 2025. The number of orders that our lab was getting throughout, basically up until March 2026 here. And we've got primary care, especially internal medicine, as a pretty good number of the orders, right? So that's excellent to see. You guys have really taken it up, and there's a good amount. Obviously, the majority of them are the memory clinic, right? Over 61% probably, but yeah, it's been a rapid uptake. So good to see.
Awesome. Question in the chat here about cost. I haven't had I have not heard any cost issues on that, but have you seen anything on that?
I'm gonna have Jeff speak to this one. There's nuances here because when the first 1,000 samples were part of a study, so a collaborative study going on, and then even when we turned it over to be the FDA approved test, insurance wasn't being billed a lot of that time. There was still the Medicare feeling out how much Medicare is going to cover this. I think as everything shakes out, especially as we start to do the test, there's going to be a cost associated, but I don't think it's going to be a major cost. But I'll let Jeff weigh in too.
Yeah. I mean, I think it's safe to assume it's covered, but we're still in that murky area where we're trying to get confirmation, but our patients aren't getting bills yet, as far as we know.
Yeah.
I haven't had any, as long as I'm only ordering it when we have objective cognitive impairment on the STMS, basically. And I've not heard a single thing. I don't know if you have, John, but so yeah, it seems like it's being covered pretty well as long as we have a good history and we have some objective evidence of deficit.
Exactly.
So
yeah.
Okay, so what I did in this situation is I ordered an e-consult. I think the order is maybe even just Memory Clinic e-consult or something. So you can kind of type that in. And I got an excellent, and maybe I'll show some of that here in a second. The report I got back from Ryan on that, which was incredibly useful and really set me up for a good kind of follow-up conversation with my patient and getting her on some treatment. But I would love to hear, Ryan, just about some of these pathways that you all have developed and kind of the differences. I think that you have the complex kind of management pathway and the e-consult pathway and others, and would just love to hear how you have, as a clinic, as a department, have really been trying to reach and meet the demand of the services and things like that.
Yeah. While I'm pulling that up, I think there is someone does have their hand up if we want to.
Oh, go for
Yes,
it.
real quick. Thank you. I had just emailed Dr. Burns yesterday, actually, because I wanted to make sure that I was associating it with the right code. And I kept thinking I should find like abnormal p-tau blood test, but there's only one that mentions the CSF. And so I think that it might be helpful for the group too. Dr. Burns just said, as long as we link it to either mild cognitive impairment or dementia, that it should be covered. But I just, every time I order it, I cringe because I worry that I'm doing the wrong thing. So,
Now, and was this
so
for amyloid PET?
yes, for the
Yes.
amyloid PET, when we have an abnormal p-tau, I kept
Mhm.
thinking,
Yeah.
and so there's an abnormal blood chemistry test that's just very nonspecific. So I usually link it to that plus whatever memory diagnosis I have, if any. And
And
then I
there'll be a
just,
higher bar for coverage for amyloid PET. So,
okay.
so the blood test should be covered. You probably want to have an MCI or dementia diagnosis in ordering them. You want to have a history, and then amyloid PET. Yeah, I mean, I know Dr. Woodward has ordered a few and gotten them paid for and covered, but you're going to probably really have to link that to make sure you have the MCI or dementia diagnosis, and it
There
should go
is
through.
there's a new ICD code, so you can be pretty specific now.
Oh,
You can say MCI due to Alzheimer's if those p-tau levels are elevated. So
oh,
that
okay.
will definitely get it
Okay,
covered.
great.
You can
Get it
also put
covered.
MCI too, but if you're putting MCI due to Alzheimer's, then that'll really help.
Okay. You also
And
mentioned some documentation to help, stating that it would be for diagnostic and therapeutic purposes for knowing if they would be a candidate for anti-amyloid therapy. Is that necessary to put in a result note or in our note prior to that?
I
hey, what do
would.
you think, Ryan?
I would. Yeah.
Yeah, I would too. I mean, they may look, and if you can say it's not just, I mean, if you say it's diagnostic and therapeutic, it's hard to argue. If you
W-
just say diagnostic, they may push back on that. They want it to be helping with the treatment decision, or, are you going to pursue that pathway of anti-amyloid or not?
When
You're not making a treatment decision. Don't worry about that. We'll make that, but are you informing a therapeutic decision? And that will really help, I think. Get it
Yeah,
paid for.
when we first started ordering these, and we didn't necessarily put that language, that was my most common like uh insurance battle was why are you doing this test? And so if you can just explicitly state even in one sentence that patient may be eligible for anti-amyloid therapy, then you avoid the prior approval battles.
Thank you.
Yeah, good points. Thanks, Mickley. Okay, I think.
Oh yeah.
We'll
So
go back. Yeah, I think the pathways. I don't know if you want to share some of those um,
yeah,
some of
maybe
those slides. I think that really kind of laid it out really well for us. Maybe we can kind of talk about those different pathways you have.
yeah, so we kind of realized that not, this sort of idea of, one patient, one size fits all is not the way to do it. When we first were running this problem, our wait time was about 12 months. So it was, if everyone's coming in through the same door, the bottleneck happens pretty quickly. So what we've done is there's obviously a lot of triage that has to happen to do this because we have to get people into the right pathways appropriately. But yeah, one we'll talk about is that you'll bring up is this e-consult. But for some patients, there are these co-pathology Lewy body Alzheimer's cases. There are these maybe dementia with p-tau negative, or something else might be going on. That's what we have our complex diagnostics clinic for, right? So these would be for people that have clear impairment and don't have a diagnosis that need to go through this more complex testing. Whereas others, they've got a very clear MCI due to AD, right? They've got this diagnosis, but they might be eligible for these anti-amyloid treatments. So then we have a different pathway for those folks versus, for some patients, they're in moderate stage dementia, but they're having a lot of behavioral issues that, SSRIs are not touching, or that, we're needing some assistance with chronic support and care. And that's where we have that more comprehensive support clinic. So, the way these things fit together, like this complex diagnostics clinic is paired with neuropsych, so we can get a little more detail of the the pattern of changes. But not everyone needs neuropsych. Not everyone can go through neuropsych, especially when they're moderate stages, right? So that's why we kind of need a pretty detailed note of what's going on, what is the problem, what is the reason for the referral, and then also what is the score on their objective test? Because if they're scoring like 10 out of 38 on their STMS, we're not going to send them through this, you know, detailed testing with neuropsych. That'd be a waste of resources and frustrate them more than anything. So that's where it really helps kind of having all the information up front of like, what's the purpose of the consult? How can we best help? And we can get them in the right pathway too.
Now, I'll just point out on the comprehensive support that clinic on the right, the lead is geriatrics APP. Dr. Byers taking that over. That's one that's more for, the journey, the course, the long course of Alzheimer's and dealing with and navigating those issues, which really a lot of it is sort of primary care. Oh, that says geriatrics APP. Should be
Yeah,
geriatric
so traditionally was our APPs that led this, and then when we hired Dr. Byer, she's going to be more of the lead. So it's
yeah, or physician. Yeah. But the other thing is we've been able to increase our throughput because the different leads, we can lean more on, APPs, and grow throughput without, we've only had about an FTE or less of physician time
yeah,
for
I'll show
for
that.
20 years. But and so now we have more, and we have Dr. Byer, so we're now at like 1.5, maybe closer to 2 FTEs now.
Yeah.
But pretty limited on the physician front. But so we've been able to accomplish this, and then I think get patients. We still got delays, we still have issues, but we're getting the right patients to the right place far more often than we used to.
Yeah, that's amazing. No, it's been, as a user on the other side of this, on the primary care side, I have had very positive experiences. In fact, we've been sharing your story with other departments and divisions, as a model of collaboration between specialty care and primary care. And so, I think that the e-consult piece has been particularly helpful for my practice, and I felt very confident in doing that. I've done it a few different times already.
Yeah.
I think one of the things, Ryan, that I want to make sure is that we're teeing this up the right way for you, right? I think
Yes.
over the years we've worked together on like, hey, let's make sure we get the MRI done. We've really enhanced how our APPs are doing these neurocognitive assessments. I think we're feeling comfortable with that. I think the next stage, and in fact, I think at least one of my e-consults that you had sent back, it was like, hey, maybe we need a little bit more on ADLs and IADLs to help me, Are there other kind of deficits you're seeing or ways for us to kind of improve our processing on the primary care side or in our notes that will make that e-consult or even just helping you on a triage standpoint be more accurate and successful?
Yeah, and so you'll notice if you ever do order the e-consult order, I do ask you to answer 3 questions that are yes, right? And so the first one being is that has that cognitive assessment visit been done? Because I can only give, as far as the information back to you guys, it's only as accurate as the information that's in the chart because that's what I'm relying on, right? So a good cognitive assessment is what I need to kind of help determine what stage is this patient in, what is their IADL status, what is their ADL status. Do they have acting out dreams? Do they have other things going on? So we built that cognitive assessment visit to basically get all the right information, right? So if you're seeing a patient and they mentioned memory, and then I'll send this e-consult and all it says is memory concerns in the note, I can't really do much with that, right? So how good is the note coming in? It really helps me. And then, is there impairment on the testing, and can I view an MRI to help go over it? And I think, so one way to think about these consults, the purpose of them. So one is we don't have any space to expand, right? So like we literally, I'm sure that's true across even if we wanted to hire like 5 new people, we don't even have the space to put them in. So this is a way that I can help input on care and decision-making, diagnosis, treatment without the space. But also it really does help you guys be more confident in what you're doing. So, when I started doing this with nurse practitioners here, um, I did a couple hundred or so throughout the last couple of years. Their confidence in the workup and diagnosis has, you know, exponentially increased as they see me sort of, affirm, oh yeah, this is the right diagnosis or stage or things like that. So in a ways, it's an active mentoring system to really build that, um, that autonomy outside of just referring everyone to the memory clinic.
Okay, so yeah, sounds like making sure, so one, you'll have some hard stops for us to help us along the way. And then just making sure that we're getting good documentation. And so you're probably looking at both our last notes as well as our APP's neurocog assessment notes primarily.
Mm-hmm. Exactly right.
Okay, did you have something on that?
No.
Okay, and then I guess from a referral standpoint, I don't know that I've referred into the complex diagnostic clinic. Is that a separate
question.
order, or if we just kind of do memory clinic, you guys will tease this out, or?
Good question. That just recently changed. So we try to make it a little bit more intentional with the order. So when you order ambulatory neurology referral, right, which is like the baseline order for all neurology referrals, we've now made it, there's some boxes that you can check. So if you are needing them to come to the memory clinic, there's a box to check for that. And then what that does is it expands out to include these different subclinics. So it'll have complex diagnostic clinic. If you click that box, it'll say what we need to get a patient into that clinic, right? Which is pretty straightforward. It's some sort of concern about decline and then an objective abnormality on the testing, right? So and then if you're really referring them to the anti-amyloid clinic, that'll have a separate thing that'll open up. They need to have an MRI in the last 12 months. They need to have, mild stages. They need to have a positive p-tau. And then we've added on ApoE, which we can talk about a little bit, because that ApoE really drives our risk benefit discussion in those conversations.
Yeah, that's actually perfect. I was just writing that down. Sounds like John has the same question because this came up recently on a patient. And sorry, I meant to talk about this when we were talking about the p-tau and I got distracted. But yeah, let's talk about the ApoE. What's the role of that? When do we order it?
Yeah. So you definitely don't want to order it in just like a screening, because we'll sometimes see it, and this is like more of outside of KU, but sometimes patients will literally come to us saying, hey, I got this positive risk factor for Alzheimer's. What do I do with this? So you definitely don't want to screen the population with these things. But it's really more for specifically if you've got a patient in mild stages that might be a candidate for anti-amyloid, that's the only time you'd ever order this test. And it really helps stratify what is their individual risk of the side effects of these drugs.
Because is that associated with, I can't remember what it's called, the ARIA?
The ARIA, yep. You got
ARIA,
it.
yeah, okay, yeah, it's associated with more of that. Okay.
Yeah, because if they have like the high risk genotype E44, that drastically changes the conversation. They still might be, we've got people on the drug that are 44, but if they're pretty risk averse and knowing that going in, like that it's twice to 3 times increased risk of ARIA, almost up to 40% in some patients, then that's we need to know that when we're having that discussion with them. Otherwise, what happens and what we found out is, okay, we have this discussion. This is what anti-amyloid drugs are. We got to go do the ApoE still, and then we need a second visit to go over their specific risk, and then all of a sudden we're backed out 3 months for new patients in the anti-amyloid clinic. So having that up front is extremely helpful.
So if you had a patient come in, and this is a very primary care problem, but someone comes in and they're like, my dad just had this positive ApoE44. I'm really worried about my progression to Alzheimer's. How do I counsel that patient to say, we really don't need to get this because it's not going to X, Y, and Z. Here's the things that you should continue to do, blah, blah, blah.
Yeah. No, I think it's one of those things where if you do have the ApoE4 allele, so even just one copy, it increases your risk by about 3 times. So if we said, 1 in 9 get it, so that 10 to 11% jumps up to about 30% or so. If you have a family history of Alzheimer's, though, like you're already at 2 to 2.5 times increased risk, there's not much knowledge gained of like going and testing yourself to like see that you do have the 4 allele. And what we say, so what we see in the data is the the lifestyle stuff really, really matters in folks that have this risk factor gene, especially exercise and controlling cholesterol and vascular risk factors, because these ApoE4 alleles are also tied to cardiovascular risk. So, and things that are healthy for the heart are healthy for the brain. So Mediterranean diet, LDL control, statins. We see people's risk of dementia lower back from kind of that 3 times increased risk back to the more neutral 10% risk when they're on statins and well-controlled cholesterol and things. So I think it's really just a
I get
counseling
asked
of
that probably
it's
once a week, Ryan, if a statin's going to cause dementia.
yeah.
Can we just like just for the record across, so we're all that does not cause it actually prevents it, right?
Right.
It's dementia. It's it's that and PPIs. It's like, oh my gosh, guys. So whoever marketing for that misinformation is just awesome at their job.
It's a lot of comorbidity stuff, right? If somebody has GERD and they're on PPIs, they're probably a little overweight, they probably have sleep apnea that's undiagnosed, they probably have a lot of reasons why they're increased risk of dementia.
Yeah,
absolutely. Okay, that's helpful. You have something else on the ApoE?
I was going to, I can't remember. I'll pop in.
Yeah, it is interesting. Yeah, I think we've been ordering a lot of ApoB 100 in different contexts, right? For our cardiovascular, we're getting a little bit more nuanced in our lipid panels and stuff like that. So the ApoE is probably, certainly a new. I have not really been ordering that much. So
I guess.
Yeah. We'll need to come up with a one pager for you guys. I think we need to do that because we're going to be doing that for kind of our larger statewide effort too. We need to, why would I order this test? So we talked a little bit about that. How do I order it? That's going to be changing. So like right now, we even order it as a miscellaneous test. You just have to type in miscellaneous order. You type in ApoE genotyping. It goes to ARUP. It at least populates into Epic. It comes in smoothly. But KU is going to be eventually doing this test. So that's going to change, or we'll have our own order.
Yeah.
And I guess I was going to ask a little bit with the ApoE, but also with just like family history. I mean, like really you're talking about like one size fits all versus more in-depth screening. So like my patients who have a strong family history of Alzheimer's disease or dementia in general, like, is it still really the same blanket recommendation for them, like the same screening with the annual wellness visit, and like you shouldn't do routine kind of more intensive screening for those patients, or should we be thinking about that in select populations?
Right. Yeah. For right now, you're doing your routine screening. You're not adding MRIs or neuropsych. Now, if you got somebody that's like super concerned, they got tons of subjective concerns, and they've got a strong family history, and they're right around age 65, like it's not the worst thing in the world to get neuropsych testing as baseline. Could you detect the most subtle changes? Absolutely, you could. But it's also not practical for neuropsych to see everybody that is 65 and concerned. So I think it'd be more select cases that you'd want to do that in. It wouldn't be the wrong thing to do it in if there's a lot of concern though.
Yeah. Well, we just have a few more minutes left here. I would, you guys have done an amazing job here at KU and in our community, but now you're kind of being asked as the brain health center for the state of Kansas, and I'm assuming parts of Missouri. I would love to hear how you're kind of rolling this out on a bigger scale across some of our rural communities across the state.
Yeah. I'll show one slide here that kind of I looked at kind of the last year of how many counties are we seeing in the memory clinic. So this is with 100 as the kind of, obviously the epicenter here right in the middle. This is the state of Kansas here. So right kind of where we're at is where we see most of our patients. We get quite a few from Wichita and Great Bend here. But any of these little shaded boxes, we've seen at least a handful of patients in. So it's 83 out of 105 counties we've seen patients from over the last year. And then this is sort of our cognitive care network team. So this is the social work team and their outreach throughout the state. But there's a lot of areas we haven't reached yet. And so some of that's going to have to come from telehealth. This is a 8-hour drive, 5-hour drive for some people. So we are expanding especially since we don't have we have a space concern. Can we see patients through telehealth? That's gonna be one option that we're gonna be doing to roll it out. But then the other thing is really trying to help create more of a spoke and hub model, right? Where Salina has a hub or Wichita has a hub, where we're able to help sites build up their local workflow for cognitive assessments, for that care support pathway, and for maybe even hopefully building treatment pathways with anti-amyloid drugs and things, getting the local radiologists familiar with looking for these ARIA events and infusion centers and things like that. So that's the long-term goal. You asked too about the rural health. I think that's a good. So we've now got, it's either a third or fourth APP fellow coming through. We do a remote fellowship for 6 months where we're training. They get to be in their own environment, but we're bringing them into the rooms and teaching them how to do the cognitive assessments, and then they can take that knowledge out to their community. So we're actively involved in that type of education pathway too.
That's amazing. As someone who's from rural Kansas and all my family's still out there, and you just see the healthcare resources. I mean, they're struggling, right? Hospitals are closing. My hometown doesn't even have a doc anymore of any level. And so, it's just, I love to hear these kind of things about how you guys are kind of trying to reach across the state there. But Jeff, did you have something? I didn't mean to cut you off there.
No,
Jeff,
that's
go ahead.
the overview of it. And just to make it a little more concrete, we're starting with 6 to 8 sites, primary care sites in this first year, where we're gonna, give them those different levels, options around those different levels, and really try to build up from there, and then add sites every year, or maybe even more quickly if things are really rolling. So, but we can do it. I mean, we're doing it. I think we're doing it here locally, across the health system. We're making progress, and I think we can take that and move it out across primary care across the state, and then build sort of the support, as we go. We do, have we built it? No. Do we have all the answers? Definitely not. And I don't think we can answer everything on day one, but we're building it with you, which is a big step. I feel like we're better partnered, us in neurology and then you guys in primary care. We're now partners and we're taking this on, but we're doing it together and we're building it as we fly it. But we're building it, which is way ahead of everybody else in the country. So
Leaps and bounds. I think I had reached out to you, Jeff, after we were at the ACP. Were you? I don't know. There was a talk kind of on this, and it was, I was the whole time I was in that lecture. I was like, our guys need to be the ones presenting this. It was just, so it was just, we're leaps and bounds ahead of that. That's really cool. How are you going to functionally do this? I mean, you can't add staff really. Kind of mentioned you guys are like kind of time limited already. How are you going to stay state now?
Well, that's where we got to figure out where the bottlenecks are, and there's a lot of them, and then take them on as they come. But we will have a team. We're building a team. We have a team. Lily Maxwell's on. She's central to this effort, as sort of a project manager and strategic person. But we'll build a clinical team. Do we have a ton of physician support to give? No, but I think we can get there with APPs, some physician support, and then just knowing that, primary care, and we're going to work with neurology, the limited neurology across the state. We can build a lot more capacity, and to be doing better. And we can do it, and it won't be dependent on us. It's dependent on primary care and us then supporting where we need to be supportive. So that's the only way we can do it. I think.
I think it'll work. I really do. I mean, I think it's gonna be really fun to follow that out. We'll bring you back in a year or two when you've had time to expand upon that model.
Yeah.
Okay. Do you have any other questions, John? I don't want to dive into treatment because I feel like that opens up a can of worms, and we've already done some talks on that. And so I think we'll go ahead and close out. And I just want to thank you all so much. I mean this sincerely. The collaboration and coordination with the Brain Health Clinic between Brain Health Clinic and primary care is really the model that we're trying to achieve from a collaboration standpoint with all of our other specialties. And so you guys are so easy to work with. And it makes us feel much more comfortable caring for our patients with these diseases. And so can't thank you enough. And we always love having you and great information. And please, it's a two-way street. So always let us know if there's things that we can be doing to help make your workflows better as well. So.
Excellent. Thanks so much, Brandon. And Lily mentioned the LEAP program in the chat. So that's our lifestyle enrichment for Alzheimer's prevention. So that's exactly for your APOE concerned folks, your family history folks. That's what it's designed for, is to lower risk. And then I should have a plug too. I don't plug this enough, but Michelle Needens and the Cognitive Care Network team, they developed a Dementia Care Assist app, right? So that's something that patient family members can utilize. Of they can type in symptoms and it'll have what might be triggering that, which things would we be thinking about. So I think it's a simple free app that they made, and something that the families can help utilize.
And I'm going to plug at you're reminding me, we're very close to deploying it in the memory clinic, an app that does that helps lead the cognitive assessment visit, basically lead you through it, asking the questions. And then it's an AI scribe where it writes that 99483 note for you. If you ask all the right questions, it'll fill out the 99483 note, draft it for you. So we're going to, as soon as we get security review, and we've been waiting for that for 4 or 5 months, we will pilot it in the memory clinic, and it'll be something that we can deploy across the whole health system. So you could use it.
That's awesome. Can't
Yeah.
wait. All right.
All right.
Thank you all for your attention today. Ryan, Carly, Jeff, thank you all. And we'll look forward to having you back soon.
Thank you, guys.
All right. Bye.
Take care.